let's talk about the greater palatine nerve, also known as the GP nerve. This is an afferent nerve for the posterior hard palate and posterior lingual gingiva. This descends through the pterygopalatine canal, enters the oral cavity through the greater palatine foramen. It innervates the palatal mucosa and bone for the premolars back, as well as the lingual gingiva. This communicates with terminal branches of the nasopalatine nerve. Here's the greater palatine foramen, and it runs forward. To locate it, it's 3 to 4 millimeters in front of the posterior border of the hard palate. It's also 1 centimeter towards the palatal midline, just distal to the second molar. This nerve runs in an anterior direction where it communicates with the nasopalatine nerve. To locate this nerve, what you could use a cotton applicator. And once you come, as I said, 3 to 4 millimeters in front of the posterior border of the hard palate and about 1 centimeter towards the palatal midline, your cotton applicator actually will dip into that area to let you know that you're right there at the greater palatine foramen. That'll be helpful when you're giving that injection. The lesser palatine nerve exits through the lesser palatine foramen, runs in a posterior direction, and innervates the soft palate and palatine tonsils. I'm going to go to the previous slide and show you the foramen for the lesser palatine nerve is right here. So when you're anesthetizing and you want to anesthetize this area, greater palatine, if you go to the lesser palatine, you'd be anesthetizing the soft palate and the tonsils, which is what we do not want to do. Hope you didn't get dizzy right there. The pharyngeal nerve is a small nerve which supplies the nasal part of the pharynx. There are some other branches of V2, the mandibular division, we need to talk about. The zygomatic nerve, which leaves the maxillary division in the pterygopalatine fossa. It has 2 branches, the zygomaticofacial and the zygomaticotemporal. Other branches are the posterior superior alveolar and the infraorbital nerve, which has 2 branches, the middle superior alveolar, anterior superior alveolar, and with terminal branches. So let's talk about these. The zygomatic nerve travels in an anterior direction. It enters the eye orbit through the inferior orbital fissure. It has 2 branches, a small branch, which is the zygomaticofacial, which innervates the skin of the cheek, and then the zygomaticotemporal, which is the skin of the temporal region. Kind of makes sense if you look at the words where it would innervate. Posterior superior alveolar nerve, or PSA. This travels along the infratemporal surface of the maxilla. This may have 2 trunks. One will remain external to the posterior surface of the maxilla. It enters the maxilla through several PSA foramina, which are on the maxillary tuberosity. The area that it innervates is the posterior of the maxillary sinus, the pulp, buccal bone, buccal gingiva, and periodontal ligaments of the maxillary molars, except for the mesiobuccal root of the maxillary first molar. So here's the PSA, posterior superior alveolar nerve. Here it is again in green. notice that it does not innervate the mesial buccal root of the maxillary first molar. So if you're working on the first molar, you'd have to innervate both the posterior superior alveolar and then the middle superior alveolar. A dental plexus, we should talk about, is sensory endings of these larger nerves that supply individual roots, bone, and periodontal structures for each tooth. Sometimes you can innervate this area here for this area. So let's talk about the infraorbital nerve, which is an afferent nerve. It's also known as the IO. It's a terminal branch of the maxillary nerve. It enters the orbit through the inferior orbital fissure. It follows the infraorbital groove to enter the infraorbital canal. It has two branches that split off inside the infraorbital canal: the ASA, anterior superior alveolar, and the MSA, middle superior alveolar. If you give an IO in infraorbital nerve block, an injection, you would also be anesthetizing the ASA and the MSA. And there's just a picture of, see the infraorbital nerve, so the infraorbital canal. Here is what the IO innervates. Notice the infraorbital foramen right here. Also note that if a nerve exits a foramen, it innervates the soft tissue. If it stays within the foramen, or goes into the foramen, into the bone, it innervates bone. The MSA nerve descends through the lateral wall of the maxillary sinus. This is also an afferent nerve of sensation, which includes, of course, pain. Its area of innervation is the middle of the maxillary sinus, the pulp, buccal bone, buccal gingiva of the maxillary premolars, and the mesiobuccal root of the maxillary first molar. The MSA may be absent in some people. If this is the case, the area is innervated by the ASA and the posterior superior alveolar, but mainly by the ASA. This will be important to you when you start to give local anesthesia. Note the green is the MSA, the middle superior alveolar. Again, if you look at the area that it innervates, it also innervates the mesial buccal root of the maxillary first molar. Okay, let's talk about the ASA nerve, the anterior superior alveolar nerve, which descends through the anterior wall of the maxillary sinus. This also serves as an afferent nerve of sensation. Areas of innervation: anterior of the maxillary sinus, the pulp, buccal bone, buccal gingiva of the maxillary anteriors. Many times the ASA nerve crosses over the midline to the opposite side in the patient. This is important to consider when administering local anesthesia for maxillary anterior teeth and associated tissues. So again, just know the ASA oftentimes crosses over the midline. And note the green ASA as it's going towards the midline. And there is the area in which it innervates. I want to get to local anesthesia, obviously. Let's talk about the IO nerve and its terminal branches. I believe I had mentioned there are 3 terminal branches. The infraorbital nerve exits through the infraorbital foramen, which I showed you. There are 3 terminal branches: the inferior, Palpebral, which is the skin of the lower eyelid. If any of you have ever had anesthesia up in that area to perhaps work on, let's say the canine, you may have noticed that the skin of your lower eyelid became anesthetized. External nasal, skin on the side of nose, again, you may have noticed that got numb. And the superior labial, if you think about superior labial, you'll know it's the upper lip. Let's talk about a review of V2, the maxillary nerve. It's sensory only. It leaves the skull through the foramen rotundum of the sphenoid bone. It includes the upper teeth, nose, palate, mouth, cheek, and temporal region. Talk about the many branches. Zygomatic innervates the skin of the cheek. Infraorbital is the maxillary sinus, the anterior and middle maxillary teeth. Pterygopalatine is pharyngeal, greater, lesser, and nasopalatine. The PSA is molars, the maxillary molars, except for the mesial buccal root of the first molar. MSA is bicuspids and the mesial buccal root of the first molar on the maxilla. Remember that the MSA is absent in many people, or some people. ASA is the maxillary anterior teeth. Palatine, greater and lesser, are hard and soft palate. Greater palatine would be the hard palate, lesser is soft palate. Nasopalatine, which exits through the incisive foramen, is the lingual gingiva of the maxillary incisors. A good hint to remember, and this sounds better than when I said it, if a nerve exits a foramen, it is going to supply soft tissue in the oral cavity. So it comes out of the foramen, goes towards the soft tissue. It will innervate soft tissue. If a nerve enters a foramen, think about when the mandibular division enters the mandibular foramen. It is going to supply pulp, bone, and periodontal structures. I think this is a good place to stop. It's an awful lot of information, and next week we'll talk about the third division, the mandibular division, and we'll do some review questions